Hello, my fellow medical professionals. It gives me immense pleasure to be able to talk to you about prudent choice of oral hypoglycemic agents. Hi, I'm Dr. Anirban Chakraborty, and I am a consultant physician with special interest in diabetes, with experience of working in India and also the NHS in UK. I hope that the approach I have to treating diabetes will also help you in choosing the right medication for your patient. So, what is the right medication for your patient? If you look at any of the recent international guidelines, you will see that the approach is fast becoming a metabolic, cardio-renal approach to improve the long-term holistic health of the patient rather than a short-term glucocentric approach. Therefore, you'll see that increasingly sulfonylureas, in spite of being a powerful oral hypoglycemic agent, are falling out of favor because of the significant risk of hypoglycemia and weight gain. On the other hand, the newer medications like DPP-4 inhibitors and SGLT2 inhibitors are fast going up the ladder in all the international algorithms. Let's talk about DPP-4 inhibitors. They're a group of generally very safe medications with no significant cardiometabolic renal outcome. That's the unfortunate bit, that their outcomes are not as such positive, but they're very neutral. In other words, their pleiotropic effects are very neutral, but their forte is safety. Out of all the DPP-4 inhibitor molecules available, linagliptin especially stands out because of its small-sized, once-a-day dosing schedule, and perhaps more significantly, the fact that it doesn't need any dose changing with changing eGFR. Therefore, in today's age of telemedicine, linagliptin has fast become physicians' first choice of DPP-4 inhibitor for mainly two reasons. One, in many patients, we do not have any baseline creatinine, but the dose of linagliptin is the same 5 mg once a day. And the second reason is that it hardly causes any hypoglycemia, and it's often quite difficult to discuss hypoglycemia prevention, etc. during telemedicine consultation, therefore precluding the use of sulfonylureas in many of the cases. So overall, it's a very safe and effective oral hypoglycemic agent. On the other hand, if we have a patient sitting in front of us who has high cardiovascular risk on any of the standard cardiac scoring, for example, any patient who is overweight, hypertensive, have hyperlipidemia, family history of cardiac illness, smoking history, etc., then SGLT2 inhibitor group of medicines will significantly improve their long-term cardiac outcome. Out of all the SGLT2 inhibitors available, empagliflozin especially stands out due to its rather remarkable 38% all-cause cardiac mortality reduction in its landmark trial. Therefore, empagliflozin also is becoming the first choice of many physicians and especially cardiologists, where cardiac risk reduction is important. Now, unfortunately in India, many studies have shown us that only 1 in 5 of our patients have HbA1c within an acceptable target range, and therefore giving either of these medicines, linagliptin or empagliflozin alone, may not be sufficient to bring their HbA1c within target. So any patient with more than say 1.5 or 2% of HbA1c than their target will probably need a combination medication. Now, remarkably, both empagliflozin and linagliptin are available as a fixed dose combination, as a once-a-day small pill, which costs even less than prescribing these two medications separately. So in many patients where you want improvement of cardiometabolic renal outcome, this medication may be considered after a short trial of lifestyle change and perhaps metformin, unless their cardiac risk is very high, in which case you shouldn't really hold back on SGLT2 inhibitors. It's quite important not to have therapeutic inertia of starting a medication like this, as time lost in the early phases of diabetes clearly will have a poor prognosis long term. Another important factor is cost of therapy. Again, clearly not all patients of India will be able to afford this medication, but for the vast majority who can afford it, long-term cost effectiveness has been shown to be hugely in favor of this medication in many of the international trials. In summary, I'd like to mention that this Empalina FDC is available in India for benefit of most of our patients who are, for example, working so that we cannot afford to have any hypos, patients who have high cardiac risk scores, and also as new research is showing that this may be beneficial in patients with NAFLD, like non-alcoholic fatty liver disease, and also in obstructive sleep apneas. In the end, I'd like to thank Lupin for giving me the opportunity to talk to you today, and I hope that this short podcast on how to improve long-term outcome of most of your patients has been helpful. And hopefully it'll help you choose the correct medicine for your patient. Thank you.